So, people say, "Oh, I've got an arthritic knee," but quite clearly, arthritic knees are not all the same, are they? They're quite different. And I assume it's only once you get that clear diagnosis that therefore you can then give a bespoke treatment. So I assume they will have different treatment programs depending on the different wear patterns.
Very much so. It's very important to recognize that knee pain from a worn out knee varies from day to day, week to week, and month to month. And that is because of a few different causes of knee pain. The first is the patient gets a toothache type of pain from the worn cartilage surface, where the underlying bone is exposed and rubbing on bone on the other side. But that is not all. If that was the case, it'll be very uniform. The meniscus, that is the shock absorber cartilage, often is crushed and spat out of the joint. And sometimes as it protrudes from the joint, when your knees touch at night, it hurts. So you get a bit of tenderness.
Yeah.
Very importantly, you get debris in the joint, and the knee does the only thing it can do, which is to basically produce more lubrication on the inside. So in a healthy knee, in a young person, it might just produce 1 milliliter of lubricant, but in an arthritic knee or a worn out knee, it might produce 50 mils. And
hence you see the swelling.
The swelling, but actually you also see it leaking in weak parts of that bag around the knee called the capsule, and that is called a Baker's cyst. So many of the patients I see have a lump or swelling behind the knee or in different parts, posterior knee pain, pain in the back of the knee. And when that leaks, it's exquisitely painful. So I've got many patients who manage their worn out knee, but when they leak from a Baker's cyst, their calf goes tight, their ankle might swell, they worry it's a deep vein thrombosis. And because they are then in severe pain as the bag bursts, they then come for an opinion.
Yeah. Absolutely. And so if we go back to the different views that you use, and you talked basically you can have wear and tear on the inside, wear and tear on the outside of the knee, and wear and tear
at the front.
So do you want to talk us through, now you've found out from that patient what you think the options are?
Yeah.
First of all, I suppose from a conservative point of view, what sort of options do these patients have?
Well, everyone gets told that conservative management of their worn out knee is a key part of the journey. I mean, these days we're treating the 100-year life. People are living a long time. And so you don't need to jump and operate on somebody. And everyone will go through their own journey of trying different things. Well, what are the principles of conservative treatment? Number one, you want to keep the joint moving well, keep the joint supple. Because if you operate on a gnarled up knee that doesn't move well and it's got contractures, then the end result is compromised. And you have to do more at surgery to get the knee straight. So the absolute fundamental is, even if the knee is wearing out, keep the joint supple. And that is what a physio should be working on, as you know, being a master physio. There is an overemphasis sometimes on muscle building and muscle strengthening, when from an orthopedic perspective, actually the range of motion is more important. Having good muscles is a good adjunct. People feel confident in their knee. And that is always nice to have. Simple analgesia, anti-inflammatories, paracetamol, ice, sometimes heat. They all help. But remember that they help because there are times when the arthritic knee is inflamed and there are times when they're not. And so that is a key part. Of course, being a master injector, that actually injection therapies have its place.
Absolutely.
Generally, they fall into three categories, in my opinion. There is the steroid injection, which is an anti-inflammatory agent, and it reduces the swelling and therefore the swelling-related misery for a period of time. There is the visco-supplementation, which is a cartilage protein gel, and the various different proprietary manufacturing of that. And that can go into the defects in the loss of cartilage surface and therefore give some pain relief. And sometimes there is evidence that if you mix those two up, it can last a bit longer than if you have one or the other. And then finally, there are the stem cell procedures, which patients seem to like to inquire about because it sounds like the
Holy Grail.
The Holy Grail, but in reality, the evidence is that it is probably just as good as steroid or the visco-supplementation. And at the moment, the evidence is that it is not superior. But these all have certain attractions and,
Yeah.
and can be tried within reason.